We'll start with a moment of reflection and a land acknowledgement. McMaster University acknowledges and recognizes that it's located on the traditional territories of the Haudenosaunee and Anishinaabe people. It's located on the territory protected by the Upper Canada Treaties, directly adjacent to the Halden Territory Treaty, and is protected by the District 1 Spoon Wampum. We do a land acknowledgement as a sign of respect for the Indigenous peoples of the region and their enduring connection to the land. And we name the treaties explicitly when we do a land acknowledgement to highlight and remember that the society that we live in is often in active violation of the agreements that we've made with Indigenous peoples, and sometimes on lands that haven't been ceded by the Indigenous peoples. And in doing this, we have a moment to think through the way our society is progressing, and how if we continue as participants in that society to not engage in dismantling the decolonization and the reimagining of the social structures, places like universities and hospitals, and the policies that support them, that we are complicit in the oppression and the violence that they cause, and continue. So I'm going to encourage you all to not be complicit. My name is Lawrence Gerson. I'm the Assistant Dean for the Health Science Education Graduate Program. I'm an education scientist in the McMaster Faculty of Health Science Program for Education Research, Innovation, and Theory, which we shorten down to MERIT. And I have a professorship, I'm an associate professor now, thankfully, with the Department of Family Medicine here in the faculty. I'm going to highlight my health science education role for a second. And I'm really sort of happy to point out that this graduate program is a professional master's degree graduate program for clinical educators seeking to build their capacity and capability as teachers and learners, education leaders, and administrators that we offer here at McMaster University. And I'm really happy to say that this week, and today in particular, marks our 10-year anniversary of being a graduate program. I was really hopeful we'd get applause when I said that. Is it okay if we get a round of applause? And 10 years is a long time and a short time. It's both things all at once. I think we all feel that regularly. But it's a really great moment to reflect and to remember where we started and to think about where we're going. And when I do that, and I think about the context of this Education Research Day, I think back to our first Education Research Day, which was part of our Health Science Education Graduate Program's Residency Week. It was just a half-day session with about a dozen presentations in a small corner of MDCL. We had merit scientist Dr. Laura Varpio as our keynote speaker, and I remember that she put up a picture of Aristotle during her presentation, and nobody in the room can confirm or deny if he was or was not a former colleague of Jeff Norman's. And since then, the HSED program has had the privilege and honor of partnering with Merit to build and offer a more comprehensive education research program for you today, and to take on the name NERD, which is a great name because we're all sort of like overly enthusiastic about our scholarship and our academics, but really to be able to feature and acknowledge Jeff Norman, who we have here today, Dr. Jeff Norman. Who's been an incredible contributor to health professions education here at McMaster University, across Canada, and around the world, advancing our understanding of clinical reasoning and clinical decision making, how we conceptualize simulation, and am I not saying the right things? and a whole bunch of curriculum reform that has advanced the way we think about teaching and learning in these spaces. The Health Science Education Graduate Program has matriculated hundreds of students in the last 10 years, and several of them are in the room. Can I get a show of hands of people that are current or previous students of the Health Science Education Graduate Program? Yeah, even in this room we've got, yeah, let's do it. Even about 50% of this room are folks that have come through our program, and it's a multidisciplinary group of clinical educators from professions like nursing, medicine, midwifery, sonography, respiratory therapy, osteopaths. We've had contemporary alternative medicine practitioners, RMTs, veterinarians, paramedics, the list goes on and on and on. And we've all been sort of brought together by this passion and this dedication for education and for the health of our communities and the people that live in them. These folks have gone on to do all sorts of wonderful things. We have people who graduated our program to go on to be program directors, admissions chairs, simulation leads, deans of schools, and we have a number that have gone on to do doctoral studies and now are training the next generation of health education scientists. And the thing that binds us all is this belief and this understanding that what we do as educators matters downstream for people. The quality of our admission and selection tools and processes, the way we assess, the way we remediate, our attention to professional development, how we conceptualize licensing, certification, all of these things add up to a professional who provides high quality care to our family members. And in this, we see that education really matters, that it is a way to improve the health of our societies. It's a way to rethink our health systems. And it's an opportunity to engage in work that promotes social justice. And so I'm very grateful today to, and I forgot my speaking notes. So, and I'm very happy today when we start to talk about social justice to be able to introduce our keynote speaker today, Dr. Saleem Razack. And Saleem joined the faculty at UBC, BC Children's Hospital, just this year, after a 25-plus career year at McGill University. He's a pediatric intensivist, and he's really well known as a medical educator and medical education scholar. He graduated from the University of Toronto. We'll give him a pass on that. And his research interests in health professions education include the intersection of assessment and professionalism with representation, equity, diversity, inclusion, and anti-racism. And he's made a number of outstanding contributions in this area, receiving a number of awards, the Haile T. Debas Award for contributions to equity, the Pediatric Chairs of Canada Award for outstanding contributions to medical education. And he's just a really great guy, funny, kind, compassionate, and really brilliant. So please welcome Saleem along with me. Thanks very much.
Hey everyone. First making sure that I can be heard and it's all working, and that's actually the biggest stress that I have. I just wanted to say thank you so much for inviting me. I actually did my undergraduate here at McMaster, and I'm having memories as we pass by the residences and so on, and memories of things that I don't remember because I'm not too sure what happened. And very excited to talk to you a little bit today about really structural discrimination and structural issues in medical education, thinking about racism in particular. So just to make sure that this works, and we get started. So I'm going to acknowledge that, excuse me, I'm going to acknowledge that I wrote most of this talk and prepared it really on the unceded territories of the Coast Salish, Squamish people, Musqueam, and Tsleil-Waututh people in the place that is known as Vancouver, British Columbia. And what's interesting about the University of British Columbia, I'm just learning, is that it's sort of built on something called the University Endowment Plans. I reflect on, who endowed what to whom and by whose authority. And it really gets me thinking about the journey of truth and reconciliation that we have to make in medical education in this country. I have no conflicts of interest to declare. And I'm going to start by expressing my gratitude to Dr. Norman. We haven't had an opportunity over the years to really talk very much, mostly because everything that you say is so golden and so thought-provoking. And I'm like, when I heard you say something, oh man, I gotta go think about that. So I have felt the intellect, but what I do want to say that is absolutely an observation that cannot be refuted, really, is that I have met about a bazillion people who have moved through your supervision, through your mentorship, and who contribute so greatly to medical education in Canada and health professions education in Canada and in the world, and that is an immense, immense legacy. So to give this talk with your name on it is certainly a very daunting task. I think I'm going to talk about things where you need to know my subject position a little, right? So I'm going to give you a little bit my subject position so that you can understand where I come from or what it's about for me. On the left, you've got all those sort of statistics, right? The things that I am, that I've done, and so on. But on the right is really the proper representation of me. So I start in the center there, and I really owe, my understanding of race, racism, discrimination, colonization, I really owe my understanding of that to the country that I come from, right? So I come from the island of Trinidad and Tobago. And that is a place, you might be wondering, like, why would somebody with a name like Saleem Razack be coming from there? I'm there by mistake, I'm there because, I come from there by mistake because, the enslavement of African people ended in the British Empire, and then a new institution was developed called Indian Indenture to work on the sugarcane plantations, and that is why I'm there. And that place is such a complex, racialized society that by about the age of 5, you learn all the rules of the racialized society. By about the age of 5. I always think of it as 202 for racism in comparison to the sort of 101 that we think about here. And the other thing, of course, is that people like me negotiate purity and mixing all the time, right? Cultural purity, cultural mixing, how Indian am I, how, all those kinds of things. And I've come to embrace the mixing and the creolization as an important part of things. My family emigrated to Canada. We emigrated to Toronto. I always like to say I became a Canadian watching American TV. Which, you'll know this from here, but it all came from Buffalo, which was where the ABC, NBC, and CBS came from. And, Buffalo's an interesting place. What that did was that gave me an idea that there was more to the world than just my own place. But it did something terrible as well. It blinded me to the injustices of my own country. So I didn't really know about residential schools. I didn't really know about the brutal colonization of Indigenous people. And, I still wax nostalgic for some of the things that were sold on 1970s TV, like Mary Tyler Moore and so on. The last thing that I wanted to tell you was basically ECC3PO and R2D2 there, right? So that's to remind me to tell you that I tend to I tend to cast a queer gaze on things as an LGBT person. So for me, and I hope I bring that to the talk a little bit. So for me, you know, R2-D2 and C3PO was the great untalked about android romance of Star Wars, which you know was there, and everybody needs every C3PO needs an R2-D2, but only the so I titled this talk "Honoring the Multitudes," right? So, and the reason I do that is because I want to really sort of focus us on the idea that many people have been brought to harm by structural racism in medical education and in medicine, right? So medical education is kind of like the handmaiden of the structural racism in medicine, right? It's one of the major ways that it's perpetuated, and we're brought to harm. And you know, I think we have to not forget that this has to be also in present tense, right? Are brought to harm as well. And you know, if there's one sort of line that you can take out of my talk, it would really be this: medicine is based upon white supremacist knowledge systems, right? And we really need to sort of think about those, and we really need to think about dismantling those. You know, this is a slide that summarizes a vast corpus of literature. I didn't present it to you. You know, I think that what I can say in a very summarizing way is the following. So, in terms of patient outcomes, structural racism, structural discrimination has been just demonstrated in multiple contexts of healthcare systems. If we move more proximally to medical education, or to health professions education, we see that framed both positively and negatively, like what things make it less so and what things make it more so, that we see that there's a vast corpus of literature that really shows that, for instance, the diversification of medical classes, health professions classes, increases the access of persons from underrepresented groups and so on. And that really, and you know, it actually gets a little bit deeper. It also includes things like how decisions are made, how well decisions are made, medical decisions, and so on. And I didn't really present you with that literature, but I presented you with these two sort of things to ponder on. One thing that I want us to really think about, like this is one of the handmaiden of medical education things, is when we teach about race correction in medicine. Okay? And for those of you who may be a little bit unfamiliar with that term, that's things like having a scoring system for some clinical outcome where race is included in the scoring, or having a normal value. An important one is glomerular filtration rate or creatinine, which has normal values based on race. And I think one of the important things we need to know about those strategies and why they're controversial and why people want them to end and why we have to stop teaching about them that way is that the real history of all of those things is that they've really been used to be inequitable to people. Really, they've been used in ways to sort of change access to renal transplant, for instance, the criteria for renal transplant and so on. On the right is an example of something from my world, and this is pediatric surgery, not exactly my world, but which really looked at the perioperative practices for children receiving very mundane surgeries, so things like tonsillectomies, adenoidectomies, and so on. And these children were judged as having low anesthetic risk, and they go through the system of care. And we notice mortality differences based upon race, right? And that really shows that, say, in the perioperative system of care for children having mundane surgeries, there's structural racism built into that. And I think that those are the kinds of things that I want us to really think about as we move through. How does social justice fit in? So Hippocrates, the sort of English translations of the Hippocratic Oath often sort of point to this particular line to sort of say that equity has always been there, right? So in this line, it's of the Hippocratic Oath. It says, "Into whatever homes I go, I will enter them for the benefit of the sick, avoiding any voluntary act of impropriety or corruption, including the seduction of women or men, whether they be bond or free." So if we translate that into modern English, it says, if I make a house call, I'm not going to sleep with the people in the house, even if they're slaves, right? So I think we can rally around that concept of professionalism. I don't think it's very controversial, even in Hamilton. But I think what I want us to think about is whether our professional obligation actually extends to questioning the institution of slavery, right? And if we continue this metaphor. And those are pictures of my kids, and that's to remind me to tell you that each specialty has its sort of creation stories, right? So in pediatrics, I've been raised with this great stories of pediatrics, right? So the stories like the creation of the first children's hospitals, right? So Great Ormond Street in London, or Enfants Malades in Necker in Paris, These hospitals of the Victorian era were created to sort of provide better care for children because there was a recognition that children needed different care. Or the great stories of, the protection of children. So many of you know this story, but the first ways that children were protected in the United States, for instance, from mistreatment, were to use the existing animal cruelty laws. Right? Because the legal argument hinged on the idea that you prove that a child is at least as worthy as an animal of protection. Those stories say something about pediatrics, right? They say protect the vulnerable. They say this is a population where the next 8 or 9 decades you might impact upon their lives. And I think that those are the kinds of things that we have to question. Is there any saviorism in that? Or is there a way to reframe the way we say these stories for greater social justice? I think 2020 has proven to us that something's wrong. Like there's no denying that something's wrong, right? So in the middle there we've got COVID, which has shown the great outcome differences based upon social disadvantage of all types, including race. We had the murder of George Floyd, which has in Canada prompted a kind of a really significant reflection in medical education, in organized medical education around anti-Black racism. And for me, I just came from Quebec. I'm deeply affected by what happened with Joyce Echaquan in Quebec. The highlighting of medicine as a major tool of the colonization process in Canada. I think one of the questions that we need to sort of think about are traditional skills ready for anti-racist medical education? So in traditional skills, so imagine yourself teaching, in a clinical skills course, you're teaching communication skills, or you're teaching physical exam skills. The kind of paradigm that we use is that this tripartite diagram is that there's the doctor, the patient, and the illness, right? And a history is taken from a patient. History and other physical exam and so on. A history is taken from the patient, and that results in some kind of synthesis where we apply a paradigm to an illness, a scientific paradigm to an illness, And that illness then gets treated, and the disease affects health, right? So I think that works. I'm going to propose to you at the end how I think it needs to evolve for us to be training people better for a world where there's structural inequity built in. The other thing that we sometimes talk about is humanism, right? So let's bring some more humanism into medicine. Something is wrong, something is missing, or it's lost. It was there before, but then it's lost, and it's lost because they're sitting in front of computers now, or we don't look at patients anymore, etc., etc. I've had some conversations with a lot of people about the problematic term of humanism, actually. So humanism is a product of the Enlightenment, the time since the 1500s to now. The idea that we don't need a kind of a deity to tell us about our morality, and that we can move forward in a humanistic way towards our fellow man, and I say man in a very deliberate way because that's probably what they meant mostly when they were doing that. And that word kind of got appropriated into medicine without thinking about its provenance a little bit. And I think that what we have to recognize is that a word like humanism carries some baggage that's not so good as well, because as a product of the Enlightenment, we have to remember the Enlightenment was not very good for most of the world's population, right? So most of the world's population was exploited during that time. And I think, this has come up with, in some stuff I'm doing at the Royal College, where we're working on the term humanism and what we really mean by it. I think one of the questions that we get is like, who gets to be human? Who gets to be considered worthy of this kind of concern? And we really need to bring that into our thinking as well. I have 3 cases, and I want to give you a case that will illustrate some of the points. So the first case is Jamal. So I'm a critical care medicine doctor in pediatrics, so this is where I'm drawing my stuff from, just to let you know. So we're having morbidity and mortality rounds. Okay, this is where when deaths occur, we discuss those occurrences to see if there's things that we can improve. And we have trainees present, and we're passing on a massive informal curriculum during that time, and a formal curriculum. And so he's an 11-year-old black boy, and he drowned in the summertime. He drowned, and in a pool, he jumped into the deep end by mistake, and he ended up drowning and succumbed to his injuries. And the mortality is being discussed, and then 2 of the attendings beside each other, they say something to the effect of, this is like the 4th kid in 3 summers who was black and who drowned. It's way out of proportion to population share, right? So then they just say that, and then nothing happens beyond that, okay? And the mortality continues being discussed. If you sort of think about it, I think that one of the things that we do in medicine very much is we notice patterns, right? We notice patterns, and so that's a pattern that was noticed. No action resulted from it, but a pattern was noticed. And in that pattern, there's probably some analysis that's required. And I think that one of the clinical skills that we want to build into, in terms of removing racism, is really to build in some analytical skills around these kinds of things. And I think of I came of age as a medical student in the 80s, right? You're supposed to be shocked. I came of age as a medical student in the 80s, right in the AIDS crisis, right? And I sort of think that I think about those doctors in New York and San Francisco who had family practices, right? Had practices who noticed Kaposi's sarcoma among their gay male patients and acted, right? I think HIV treatment would be nowhere without that. right? So these are the kinds of things that we want to build into what people learn and know. So what is that? I think one of the clinical skills we need to develop and really be deliberate about is structural competence. So this is noticing structures, right? So we noticed that Jamal is part of a pattern of black children. But then it's a question of why. Why? What is the reason? So we encourage metacognition. So what knowledge system is being accessed to see this pattern, right? Like so, the knowledge system that I'm accessing is through reflection, right? And I'm accessing probably scientific knowledge. If I applied a scientific paradigm to it, I wouldn't really get good answers. So I might also have to refract a little as well and see what other knowledge system lenses I can apply to this, right? Like, so could I apply, what about who gets to learn to swim? How do public swimming pools work? So I could sort of move into more the public health sphere or the more upstream sphere. And I think that those are the kinds of things that we need to do with students, residents, other health profession students, to really get them reflecting and refracting around patterns. And if we did that, what we would come up with. So in medicine, and I can only speak for medicine, I think there's high value placed on the simplest answer in many specialties, right? Like so, there's the presence of shock and vasodilation and purpura on the skin. So it's probably meningococcemia, right? Like so the one outcome, the one causal agent answer to disease, and we teach that. And I think we have to change a little and maybe do a little bit of an ecological model of disease, right? So we should ask more, why this disease at this time in this person to this degree, right? And if we did that, we would go with bio, psycho, and social. We all know those things. And we would probably have a bit of a pie assigning importance, and the importance may vary with context of care. But we would also bring in notions such as socio-political, economic, and environmental, so planetary health as well. And I think if we did that, and we sort of did that in our teaching, we don't have to do that with everything. Sometimes when you have purpura, shock, and fever, and you really just should give ceftriaxone and it's going to get better, and maybe a few boluses. But there's also a time to reflect on the broader issues as well that is part of our job. And for those of you that know, this is a cultural safety idea, right? So cultural safety was developed by Iria Petty-Ramsden in New Zealand. She was a Maori nursing educator. And the kind of revolutionary thing that she did was, and the picture on the left is actually a picture of the Treaty of Waitangi. For those of you that don't know, the Treaty of Waitangi is to New Zealand what the British North America Act is to Canada. It's kind of like the founding document of the modern state of New Zealand. And what she did was she related Maori health back to the obligations and rights that were in the Treaty of Waitangi, right? So what's kind of interesting in the doctor-patient encounter, or the health profession's professional-patient encounter, is that she got us to think beyond the dyad, okay, and got us to think about the socio-political and geopolitical context right there in that moment, in that room, not just some kind of abstract concept, and got us thinking about why this patient at this time and how is it happening. And I think we can really teach that. And cultural safety is, providing safe care is something we can rally around. I think the other thing we need to know is about the profession as part of racist structures, right? So I put some examples up there. So the first two are examples from Canada, right? So the unethical nutrition studies on Indigenous people, forced sterilizations of Indigenous women. There's an example from the United States of the CD trials, the Milledgeville Hospital, the examples of Nazi medicine. Some people react when I write Nazi medicine and talk about it being quite exceptional. I actually think if you read the literature and history, it's actually not that exceptional. And the profession was a very significant part of that. You know, what I think we need to sort of bring into people, like this is a thing that helps us understand, like just as much as we have the good, you know, we also have this, and we have this to dismantle. And in terms of forced sterilizations of Indigenous women, what I think about is I think about the people who did that, being graduates of programs that are present in this day and in this moment, you know, like that are in full continuity with that past. So, in terms of how do we instruct people, instructional competency, I'm not going to talk about this very much. I'm going to basically tell you that there's a whole suite of ways to build structural competence that involve critical reflection skills, dialogic kinds of teaching, so narrative medicine, as many of us talked about yesterday, where we can see structure, we can acknowledge, we can appreciate the effects, and this is the extra, this is the thing that we're not doing as well. We need to get people to very seamlessly drop out of a scientific paradigm and maybe apply a bit of a sociologic paradigm to what they're seeing as well, in order, so that's the refraction idea, to really be critical, and to, one of the ways they can do it is to value interdisciplinarity. So what about case 2? So case 2 is Dr. Khan. Something snaps in Dr. Khan. There may be a Dr. Khan in the room. There sometimes is. I just want to make sure that you know that it's not you. So Dr. Khan is an internist, and she's a well-regarded educator. She's been doing it for years, and she has her group of students, medical students, that she takes on her reflective practice sessions. You know, at McGill, this was called the Osler Fellowship, where they were, we had our 6 students, and we would do reflective practice with them over the years. And that has some sessions associated with it. So she's at this session, and in the session, colleagues are talking about Indigenous health. And they talk, and the doctors are talking about, the rate of child mistreatment in Indigenous families, and how the families just are not equipped to look after children, and sometimes it needs to happen that children are removed. Without any historical context, and in a very othering way, it's talked about. And one of her students sitting beside her is Indigenous, and that student's face drops like this, right? And something just snaps in her, and she said, this thing that I've been part of for the last 30 years, it's not me. It's wrong what we're teaching. And I'm quitting. I'm quitting doing this course. And she, sees the distress on her Indigenous student, the student in her group, and she doesn't feel empowered to bring it up in this group. So she quits. She's a casualty of it all. So I think what goes on here is some of the implicit agreements of a medical education, right? You may or may not agree with me here. This is what I think the implicit agreements are of a medical education. But when you join medicine, you have done a few things, or I'll just say I did a few things. I agreed to think a certain way, right? I agreed to join a knowledge system, right? Like I'm going to try and think scientifically about problems. And I'm going to view that as the best way to think about problems. I'm, forever and ever, and those of us who are physicians or other health professions as well, we are going to agree to be reviewed by peers forever and ever, right? So we're going to agree to be regulated. And thirdly, we may not have agreed to this. I don't know if I agreed to this when I joined medicine, but it happened. I agreed to reconfiguring myself, right? So I will reformulate my identity. It will incorporate a professional identity formation. So Dr. Khan had all of that happened to her, right? And then she was teaching in this structure, in this system. And I think what happened to Dr. Khan was that she all of a sudden appreciated professionalism as a pedagogy of privilege. So professionalism is a social construct. There's a number of discourse analyses that have been done on professionalism that show what I've distilled here. One of the kind of things about medical professionalism is this notion of elitism and noblesse oblige, right? Like the idea that I will get prestige from society because I have special knowledge, and I will care for those in my charge, right? You know, and I very purposely put it down because I actually want to make sure that you know that there's quite a bit of hierarchy in that may not be good for the world that we're in. And I think where it's not good is that we need to be teaching and recognizing that physicians are beneficiaries of healthcare systems that were designed explicitly to discriminate and to be inequitable, right? So that in that system, a new formulation of professionalism is necessary. So how might we envision new inclusive formulations of professionalism? I want to go to that second point about sort of diverse persons. So Dr. Khan is a diverse person. I gave her a name, Dr. Khan. You might imagine a South Asian woman, which is what she was. She is. The construct of professionalism that is put on people carries a baggage of race, of maleness, of Eurocentrism, all those kinds of things. And there can be these moments of inauthenticity that happen when you realize that that construct is not you, right? And I think that that's sort of something that happened to Dr. Khan. And I think we can envision new and inclusive professionalisms where the hierarchy is not there. And you know, one of the rallying things that I've been working with is the idea of professionalisms of solidarity, where we are, you know, inside the society we seek to serve, and we teach that way. So she negotiates authenticity versus complicity. She probably had insider-outsider migration, you know, moving from an outside to an inside. And what happened was she had a moment of clarity. And I want you to reflect on any moments of clarity that you've ever seen, you know, you've ever been part of, you know. You know what I'm talking about. It's that thing where you can't... I took my mother for an INR. My mom, she's gone now, but she never had a normal INR in her entire life, okay? She was, every Monday, demented as she was, we were taking her for an INR, okay? And it was a big outing. And I went and I took her there, and one day I saw that we went over here to check the hospital card. We had to go up to the 3rd floor to do this, and then we had to go here to wait, and we had to pull a number thing to get the blood test. And the moment of clarity for me was, what if somebody didn't speak English? You know, and had to go through this process of getting an INR. So the other thing that we need to do, so, you know, Dr. Khan is in distress, right? But I think we need to do some deep listening to people who are in distress. And deep listening is attentive, generous, it's trusting, and it lives in ambiguities, right? Like it's okay that Dr. Khan's experience is what it is, and that others' experience of professionalism is not quite that. So we need to really encourage the development of deep listening. So case 3, Journal Club. So this is Critical Care Journal Club. Okay, we're discussing this Wednesday afternoon. We're discussing COVID outcomes and race. Okay, so it's been this major paper in the journal Chest. Chest is a major journal in our world. And the supervising attending sort of who's supervising the journal club says, you know, race has been identified as a risk factor in critical illness in COVID. And a racialized fellow sort of thinks to herself, you know, should it really be called race, or is it being racialized as, or experiencing racism as that is the more correct term? And she's saying, what she's sort of saying is, when you say race, you situate it within the person as a deficiency, rather than in that person's relationship to a racist society, say, which is the true social determinant of health. So she raises her hand, and she's brave, and she says exactly that. And the supervising attending says, you know, this past peer review, and it's in the journal Chest, and we're just going to refer to it, and she rolls her eyes a little, and we're just going to refer to it as race, okay, for the rest of this talk. It's an interesting thing that you said, but, you know, that's not really what the focus of this paper is. So that person is silenced. So I think this case brings up a really, really important kind of epistemological thing that we need to think about, right? So what does it mean to define a population at risk, right? And I think for the epidemiologists in the audience, I really think the graduate students need to be taught this particular aspect in a deep way. There is no, I'm going to say no, like with absolute terms, but maybe you'll think of an example that isn't, but there is no population that is not defined socially in epidemiology, right? South Asian men at risk of type 2 diabetes, right? I'm being socially defined for this disease risk that then gets studied and then creates different belt sizes in me, like 35 inches, which I am far exceeding, I just want to let you know, as opposed to 40 inches, right, for the risk, right? So I think we have to really talk about how populations are being defined for the observations that are being made about them in very biological ways, right? So they're being socially defined to make biological observations or to explain their differences biologically. And I don't know if there's a problem with that. There may not be a problem with that, but I think you need to make sure that people know that when they're learning it. What about the 70-kilo white male? So I learned about the 70-kilo white male. He's a rainbow unicorn. Did you? And maybe it's not done anymore. So I learned about his GFR, I learned about his PFTs, I learned about, what else? The 4 years of pediatrics is about teaching about how children are physiologic deviants from all of that. Though, during COVID, I did look after some adults, and it turns out that the pharmacology seems pretty similar. But I think when we organize knowledge that way, with a center, so the center is a 70-kilo white male, and then everything else is kind of eccentric from the center. I think we create interesting knowledge problems, right? So if we teach that women present with symptoms of myocardial infarction atypically in comparison to men, and it's a social choice to label those symptoms atypical versus typical, right? Of course we're going to notice outcome differences in the treatment recognition of myocardial infarction in women. Right? Well demonstrated. Right? Like, so I think we have to look at how we're talking about knowledge and difference in medical education. Oops. I'm just going to look at time. Yeah, I think I'm going to skip that one. And I think the main thing that I want to sort of bring up is the idea that what we're really trying to teach, and we need to bring into our teaching through that reflection and refraction idea, is the concept of critical consciousness, right? So we need to develop that in clinical skills teaching, in problem-based learning teaching in cardiology, in, on the phone in the middle of the night with critical care consultation. We need to develop those critical consciousness skills. And what is critical consciousness? So critical consciousness is an idea developed by Paulo Freire, who really, he's a Brazilian educator. He wrote a book called Pedagogy of the Oppressed, where he really brought the idea that individuals are conscious and reflective, and they're able to appreciate structures of inequity and social contradictions, and that they are able, as a collectivity, to commit to act, right? So this is the kind of idea that I want to bring into clinical skills teaching, is structural competence and committing to act. And what is it that we need to understand? We need to understand the logic of the medical education system, right? So medicine is based upon white supremacist knowledge systems. It's racially hierarchical, which includes all of those things that I've put there. It's patriarchal, it's cis and heteronormative, and it's profoundly ableist. And these are the things that we need to uproot and bring out and dismantle in curricular learning. And doing so, I think we have to remember who's not at the table, or who's not been at the table. Like, who's not been at the table while all of this has been happening. And we need to have the habit of mind, in residency program committee, in curriculum committee, we need to ask, the way we're teaching about, the way we've designed this OSCE that is seeking to be culturally sensitive to, say, Chinese families, are Chinese people at the table as it's being discussed? And I think, I told you that all of the processes in medicine, everything in medicine depends upon some kind of peer review, getting a grant, reviewing your curriculum, reviewing your practice, all that sort of stuff. So we really need to look at peer review and decolonize it and make it anti-racist. So diversity of reviewers is a really important part of things, but it isn't only the thing. We need to have training of reviewers, we need to question the knowledge systems of biomedicine, and we need to engage communities in identifying problems. So I told you that medicine was a pedagogy of thinking a certain way. So it is, and it's beautiful. It is beautiful to see the sodium being 133 and the urine output being reduced and diagnosing SIADH. It's beautiful, but maybe that's not the most beautiful thing about it. But it's what came to mind right now. And I think there's beauty in that, but I think we also need to bring in some criticality into what people learn as well. So they need to think about critical pedagogies, and some of you might see that as a pollution of the medical education. I would like to challenge you and ask you to think about it as maybe a way to clarify medical education. And a way forward might be to use the indigenous knowledge system of Twoeyed Seeing, right? So knowing when to look at something a certain way versus another way. So I presented to you the doctor, the patient, and the illness. What have I changed here? I changed the arrows. The arrows go both ways. So everything is dialogic. And in terms of the doctor and the patient, it's not only the genre of taking a history. Taking a history is a literary genre. But there's another literary genre that is useful. And that literary genre is hearing and understanding a patient's story. So patient narrative is important. Disease and patient also work together, like in both ways. And in terms of paradigms, the doctor or the health professional is able to question the paradigm, right? Is the scientific paradigm the right one to be using here? So the main thing that we're trying to do, the reason we're doing this is because healthcare systems were designed to discriminate. The Indian Hospital Act was designed to provide substandard care to Indigenous people. So what's a medical education researcher to do? Just a few slides and then we're done. I think the medical education researcher needs to valorize and study phronesis. So the major thing that we do is we act in uncertainty in socially, contextually meaningful situations. And I think that what we have to do is understand that that's the end product of a medical education and really study those issues, like how do students develop phronesis? How do residents develop phronesis? How do they develop prudent action in the world? Practical wisdom. Another one is researchers need to reflect on the quantifying of qualities. So when you create a Likert scale about empathy for the multiple mini interview that you're running, where somebody can take off a 6 or a 7 on that Likert scale for empathy, what is the construct, right? The construct that arrived there is a socially determined thing, and it may have equity concerns within it. It often does, actually. Embrace the interpretive. I may piss off Dr. Norman a little. I agree that, so many of there are two kinds of why questions, right? So there's why, what's the mechanism, right? But then there's why, what's the motivation? And what's the logic of the system that it's in, right? And most of those why questions really need kind of socially interpretive-based methodologies. Seek theory-praxis linkage. So people who are on the praxis side, we need to ask why until we arrive at our theoretical understandings of what's going on. People who are on the theory side need to ask how, at least 6 times, not 3 times, as to why they're getting what they're getting. Question the white gaze and its power over us. So find the counter-narrative, find the meta-narrative, and for me, cast a queer gaze on things, which I hope I've done today. So 2 metaphors for the journey. You know, if all you have is a hammer, then everything is a nail, right? So we have to question when the scientific paradigm doesn't work. So my metaphor, and I hope you accept it, it's a bit risque. So missionary position is fine, okay? It works. It produces babies. But sometimes we need to go full-on Kama Sutra with our knowledge systems in order to really understand patients. And this is the absolute last slide. So where do I fit? As a critical care doctor, I am the parsley on top of that meal, which is the roast beef. Children learning to read and write, children getting vaccinated, their mothers having a good education, and if I can, with my critical care fellows, we are the parsley people. It means that we're in a good restaurant, but if I can, with them, help them understand that they're simply the parsley of all of this with these patients, then I think we can maybe start to bring in anti-racist medical education. So thank you very much. I think the issue of appropriation is very important. Like, for instance, with cultural safety, and I always mention Uriah Petty Ramsden because nobody else does. And it's become we need to know that came from Maori Health and from that woman. I think in terms of Twoeyed Seeing, a couple of things. So I actually came to it reading a paper from Australia, okay? So McKibbet. But Twoeyed Seeing is a Mi'kmaq. It comes from the Mi'kmaq people, right? So I think what I learned from that is that the notion of Twoeyed Seeing, which is really an idea that you can apply, you can see things through a certain, I guess, theoretical lens, different theoretical lenses, in useful ways. I think what I learned from that is that it has great resonance with many indigenous peoples all over the world, right? Like this particular concept. I think that it should, if it comes into our world as a way of doing it, it should always be understood what its provenance is, right? Its provenance and its reciprocality is built into how we teach it, who teaches it, all of those kinds of things. If if you see something, say something, and say something in a good way. But I also want to temper that with the notion of strategicness, because it is not without consequence to speak up, but particularly for racialized people and other minoritized people. The only way forward is really, in those moments when the Band-Aid is ripped off, somebody has to say, what am I seeing here? You know, what are we seeing here? Like let's step back and do that. And you know, there's power dynamics in all of this, but I do think that structurally, you know, things like accreditation and so on have built a lot of power to the learner voice, for instance. So it can be brought up, and it can be done in good ways to do that. And, you know, I presented the case of Dr. Khan, who quit, you know, maybe that's a bit of a downer in a way, but it's a true thing, you know. Maybe it's a bit of a downer, but, you know, if we find courage, if we find networks of support as well, you know, so allies, then we don't have to quit. Then we can be part of the dismantling. So when you say, so again, I told you I came from the Caribbean, right? Like, it's like the racial categories do not make sense. The main racial categories here do not make sense over there, right? Like, so there's a lot of stuff that goes on where there's transfer of medical knowledge that shouldn't be transferred in that way, okay? Another, you know, I didn't really talk about it much, but it's actually one of my favorite topics, which is really the philosophy of epidemiology, actually, which is like this idea of how do you measure a population and what is a population, right? Like, so I think that we should accept that populations are being socially defined, usually, almost always, I think, are being socially defined. And when we make observations about that population, and let's assume that we can measure them well, and there's a whole complexity to what does it mean to measure a population, I think that when we seek the mechanistic explanations, right, we have to stop with the biological essentialism as we're making those explanations, right? So there can, and you talked about race being maybe a dependent variable because it's rather than an independent one, and I think that is trying to say that same thing that you just said there, as well as when it's really being used as a proxy for something else, right? Like, so maybe the proxy is experiencing racism, it's being used as a proxy for experiencing racism, and then maybe we should insist upon a bit more cautious use of the word in that very prestigious paper because it affects the knowledge of many, many people because it came out in chest, right? So that would be my thought. And the last thing that I would say is that there's also, we need to recognize the healthy social loading to even the science, right? So there's a book called The Mismeasure of Man by Stephen Jay Gould, which really talks about the history of intelligence testing, right? So the early years of intelligence testing were the years of Ellis Island in the United States, right? So the years of immigration switching from Northern Europe and the United Kingdom and the British Isles to Eastern Europe and Southern Europe, and they didn't want them. So there was a bit of a use of intelligence testing to sort of say that they weren't as smart. I think we also need to know the social context in which the science has arisen as well.
Thanks so much, Saleem. One more round of applause.